We have Dr. George Turabelidze, who will give us a presentation on vaccine-preventable disease elimination. Dr. Turabelidze is a Missouri State epidemiologist and a board-certified pediatrician. He has 20 years of experience as a public health practitioner and over 30 years experience as a clinical doctor. Dr. Turabelidze is an external faculty at Washington University School of Medicine and St. Louis University School of Public Health. He has over 60 scientific publications in peer-reviewed journals. Thank you for joining us, Dr. Turabelidze.
Hi, everyone. I want to thank Missouri Immunization Coalition for inviting me and Dr. Miller from State Health Department to talk with you. And thanks, Dr. Miller, for a very thoughtful presentation. My presentation is kind of more down to business. I will talk about vaccine-preventable diseases, and we'll look at if we have a path to elimination in Missouri. And this will be in the context of past, present, and future of vaccinations in this country. I will talk a lot about vaccines, but I have no affiliation or no consulting jobs or any other relationships with pharmaceutical companies, just my disclosure. Unfortunately, we live in times where parts of our society are questioning vaccines and even claiming that they are dangerous. But the truth is that vaccines are, vaccines are one of the most effective public health tools in disease prevention and death prevention. The only disease that was eradicated, smallpox, was eradicated due to vaccine. People forget that. And polio is next in line. In a study of a single US birth cohort, analysis of vaccinations for 13 different diseases estimated 20 million cases of disease prevented and more than 40,000 death cases prevented. Net economic benefit just in USA is $69 billion per year. If we look globally, analysis of 10 different vaccines in 94 low and middle income countries showed that investment of just $34 billion in immunization programs results in savings in nearly $600 billion in reduced cost of illness and nearly $1.5 trillion in broader economic benefits. If we look at COVID vaccinations, there was a study published by Commonwealth Fund in the end of the year 2022, and they estimated that through November 2022, more than 18 million additional hospitalizations and more than 3 million deaths were prevented through COVID vaccinations. And just like you don't need a reminder, but just to take a look how impressive it is, more than 90% of vaccine-preventable diseases prevented, and some totally eliminated in the United States. We don't have, obviously, smallpox, but we also nearly don't have diphtheria. We don't have polio, and many are more than 99% reduced. If we look globally, this is a publication of a modeling study in Lancet that looked at vaccinations against 10 different major pathogens, by the way, major pathogens in 98 low-income countries and middle-income countries across the world. They found that vaccination for those 10 select pathogens would avert 69 million deaths between 2000 and 2030. Most importantly, this will be in children under 5 years of age due to notably measles. Over lifetime of 2000-2030 birth cohort, 120 million deaths will be averted through mostly measles and hepatitis B death reduction. And increasing coverage just in one birth cohort, 2019 birth cohort, would reduce lifetime mortality by 72%. So just a reminder how important vaccines are. Now, before we start talking about future vaccines, let's look at what vaccines do in general. As you know, when we inject a vaccine, we're introducing antigen or antigen adjuvant together into cells. And these are so-called antigen-presenting cells. And those cells, they process the antigen, they become mature, and then they transmit signal to B cells to make antibodies, to T helper cells to help those cells make antibodies, as well as to cytotoxic T cells, which can destroy cells that are infected. So the endpoint of vaccination is not only developing antibodies, but also developing T cell immunity. As you know, we have multiple classes of vaccines. Not every vaccine fits exactly in one class, but we have live vaccines, inactivated vaccines, nucleic acid vaccines, recombinant, and so forth. And what is common between them, that most of them obviously are safe, but they have a problem with immunogenicity and efficacy. Or, for example, recombinant vaccines, they are quite efficacious, but because of the evolutionary mutation in the agent, over time they can become ineffective. Why I'm saying this? I'm saying that we have different kinds of vaccines, but we still have more work to do to make them better and safer. Overall, conventional vaccines, they work well, mostly against pathogens that don't change much, like measles and mumps. Measles vaccine has been working well for decades now. But if you have something like flu that changes all the time, then you need a conventional vaccine that you have to give it every year, which people are sick and tired of it. Conventional vaccines also are not efficacious with the infections that change after they infect the person, such as HIV. That's why we don't have HIV vaccine even today. And they mainly elicit what I showed on the previous slide, mostly antibody production, but very often we need the T cells being involved in the immune defense as well. And there is talk about gender bias with some vaccines. And what does it mean, gender bias? So there is an observation that, for example, flu vaccine, pneumococcal vaccine, they work better for females than males. And why is that? And I don't think we have one single answer, but more kind of plausible answer is that many proteins involved in immune response, the genetic code for that protein is on the X chromosome. Females have 2 X chromosomes. We males only have 1. So with 2 chromosomes, X chromosomes, you have a better chance of expressing those genes. And that's why they may have a better chance of having better response to vaccination, I mean females. But don't get too excited, that comes at the cost. Because of that, females also have more side effects with vaccines, and females are more prone to autoimmune conditions, which is when your immune system is hyperactivated. There is also a role of hormones. Estrogens tend to help immune response, and testosterone tends to kind of push back against that immune response. And of course, the conventional vaccines, they need a requirement for transport and storage, and which is not a minor thing. If you look worldwide, globally, we spend $300 million just on transportation and storage of those conventional vaccines. Now, talking about future vaccines, I want to talk about nanovaccines. They are kind of not exactly future because they're already here. mRNA vaccine basically is a nanovaccine. And what they do, that they use nanoparticles as carriers and adjuvants. And because these particles are so tiny, they're almost the size of the pathogen itself. They can better stimulate immune system, the antibody production, as well as cellular immunity. And unlike conventional vaccines, nanovaccines are involved mostly in subunit vaccines that contain just enough antigen to trigger specific immune response we want. Also, another advantage of nanovaccines is that nanoparticles protect the antigen within the particle so that antigen can be delivered exactly where we want it to be delivered. And because they are coated within the nanoparticle, antigen is not exposed to the entire circulation, and we do not develop unnecessary immune response. They can deliver just enough immune response that what we want. And delivery system could be different. They could be polymer-based, metallic nanoparticles, liposomes, the ones we use in mRNA, inorganic particles, and composite particles. Right now, there are at least a couple of dozen, and more is coming, of nanovaccines in clinical trials worldwide. mRNA vaccines. So unlike conventional vaccines where we deliver antigen to the antigen-presenting cells, here we are delivering actually the genetic information to the cell. So this is essentially biological software. We are delivering instructions to the human cell, telling them, you cook this protein. And that's what cells do. You know how quickly they do that? Once you inject someone, in half an hour, those cells already making the protein the mRNA tells them to make. And you don't need a virus to make a vaccine, and you can send the genetic information required to make a vaccine from one country to another just by internet, and you can make an experimental batch of vaccine just in a week. That's how little it takes to make the vaccine. So essentially, it is a plug-and-play technology which can be rapidly developed at low cost. mRNA vaccines can target any pathogen. They can encode more than one protein, and the production can be scaled and standardized, so you don't need the giant manufacturing facilities. And mRNA vaccines and therapeutics can be produced in one location with the same process. So thinking of mRNAs and the opposition we see in the communities and in the population, just one comparison came to my mind one day. Remember, we don't remember, I'm not that old, I don't remember when that was, but when automobile was introduced, people were laughing. I mean, horses are forever, what is this strange thing? It will go away. But we all know how that story ended, right? So I think that's my prediction. You can say that Missouri State Epi said that many years ago. My prediction is that mRNA vaccine will follow the same path of automobiles. And right now we are looking at a whole bunch of new mRNA vaccines coming. Of course, the ones we want to mostly worried is the coronaviruses. We simply cannot sustain the coronavirus vaccinations for COVID-19 the way it is right now. We need vaccines that are more immunogenic, where immunity lasts longer, and that protects for wide range of different coronaviruses instead of making new vaccine every time new variant comes around. This is not sustainable. And you know how many coronaviruses out there? 500 just in bats. And they can potentially be transmitted to humans. So this is the work being done, and hopefully we'll have a broad vaccine inducing broad immunity against all coronaviruses. And other than that, there is different companies, institutions, universities are working on mRNA vaccines for C. difficile, for genital herpes, for hepatitis C, HIV, universal influenza vaccine in University of Pennsylvania works on that, leptospirosis, malaria, norovirus, tuberculosis, and many more. Actually, some people say we are entering golden age for vaccine development. And it's not just infections, it's going to be vaccines for non-infectious conditions, such as vaccine for cancer, vaccine for food and environmental allergies, vaccine for genetic diseases. For example, mRNA vaccine can deliver the missing gene to where it's supposed to be or repair the damaged gene in those who have those congenital problems. mRNA can help prevent heart attack and stroke. The vaccine can target liver cells making cholesterol so that you are making less cholesterol and you may have a less heart attack. Vaccine can help mRNA vaccines with heart failure. mRNA vaccine can instruct T cells to digest that fibrous tissue that these people with heart failure have, and because of that, when this fibrous tissue goes away, it's replaced with normal muscle, and the heart function can be restored. There is also mRNA vaccine for neurodevelopmental disorders in works. There are about 1.5 million viruses just in the animal world, and up to half of them can infect humans. So demand for vaccine is here, and it's only going to get bigger. It's not going anywhere. 40% of all death globally is due to infections. So clearly we need vaccines. We need new technologies with alternative adjuvants for single-shot vaccines. We need to improve our technology with injection with multiple antigens at once. There is work on self-amplifying mRNA vaccines. There is work at MIT at self-boosting vaccines. When you inject a person once and then don't have to come back for boosters, don't worry about your jobs. You still have more vaccines to give. There is also work on edible plant-based vaccine materials, needle-free skin patches, and microneedle injections. Of course, not all of this is going to make it to the end where they become licensed and used, but I'm just telling you what the work is going, so that what may happen, and even half of this happens, this is still really mesmerizing how technology can help us. Now speaking of microneedles. Microneedles, the idea behind microneedles is that you can elicit better immune response with the same dose of antigens using microneedles. Microneedles are essentially very tiny, hundreds of tiny needles. They are only several hundred micron size. They are mounted on adhesive backing, and a person can administer it themselves and on the specific sites on the body. And because the needles are so tiny, they cannot penetrate, and they are almost pain-free. And why we're kind of fascinated with this, actually the other day I saw they already developed movable printers, and those printers can print hundreds or thousands of those patches a day. And then in the future, there are going to be 3D printers that will be printing as many as you want of those patches. It turns out that when we inject conventional vaccine, we go through the skin and we inject under the skin and even into the muscle. But the thing is that there are not many antigen processing cells there. Turns out in the skin itself, within the skin injection, you have more antigen processing cells, and therefore you actually get better immune response, antibody, as well as T cells by intradermal injection. And that's the whole kind of concept behind the microneedles. So because of this technology, you have not only increased vaccine effectiveness, but you also don't need a cold chain. You need less personnel to administer vaccine. There is no sharps waste. There is no multi-dose vials. There is no need for vaccine reconstitutions. And the technology, once it's established, it's cheaper. And you can do anything. You can do live vaccines, DNA vaccines, mRNA vaccines. Anything can be used with this technology. And the future vaccines, again, I want to mention a work on therapeutic vaccines. Vaccines we give are for prevention, right? But there is also future for therapeutic vaccines, where we give it to treat conditions where the infections are persistent, such as shingles or HPV, for example. We also need vaccines that are under development that can help with long-lasting infections, such as HIV and tuberculosis. And those vaccines are tricky because just antibodies are not enough with these infections. With these agents, they can hide from immune system within the cells. So you need to activate the T cells as well, not just antibodies, to have a successful HIV or tuberculosis vaccine. And we have vaccines for, we will have vaccines for autoimmune disorders and allergies, so-called negative vaccination, because here instead of inducing immune response, we want to do that remove that immune response that we don't want. That's why it's negative vaccination. Surprisingly, we're going to have vaccine for addictions, for like a cocaine addiction, for example, or nicotine addiction. And finally, the ones that I already mentioned, personalized vaccine therapeutics for cancer. And this is probably the most completely inspiring technology. With cancer, it's very hard to find. It's not a spike protein on coronavirus. You have many, many targets, and hard to see which target is the best chance to help person with cancer. So with personalized vaccine therapeutic, what will happen in the future, you go to the doctor, you look at your own cancer, that cancer will be investigated, you will find the best target for mRNA vaccine, then will be mRNA vaccine developed specifically for you, and that vaccine will be given to you, and then those antibodies will attack your own cancer. That's the vision, and it's totally inspiring and could be completely game changer for our generation. So we're going to use also artificial intelligence, machine learning, and robotic process automation to catalog all the knowledge we have about viruses and bacteria, predict potential variations and mutations, identify antigen targets while eliminating human error. These technologies can accelerate identification of most productive mRNA sequences that we will use in vaccines. Right now, actually, Moderna is working using AI to improve the mRNA vaccines, making it safer and more stable by minimizing lengths of the RNA strands. Now back to the reality. We'll talk about vaccine-preventable diseases in Missouri. What is going on? So with varicella, you see we have a strong downtrend, and this is consistent with the national data. For measles cases, mostly it's flat and low, but there are a couple of years when we had these outbreaks, and overall that caused the uptrend. As you know, nationally, measles cases are up, primarily because of multi-state huge outbreaks in 2018 and 19. Pertussis cases, similar to national trend, we have a strong downtrend. Meningococcal cases, again, same thing. Nationally, as well as in Missouri, we have a downtrend in cases. For HIV cases, nationally, they are very low and flat, and these are invasive HIV cases. We are basically flat as well. There was a couple of years when we had more than a handful, about 4 cases, and all those cases are among unvaccinated. That particular year, we had a few cases in the Amish community, which, as you know, has low vaccination rates. Tetanus cases is basically low, flat, and even going down more. Strep pneumonia cases, here we don't have much data in terms of years. Trend looks flat, but if you look nationally, the trend is down, especially after introduction of PCV13 for the cases of invasive strep pneumo are going down. For HIV, for quite a while, our cases were very low. But then, as you're aware, there was an outbreak of hepatitis A in homeless population in many states, including Missouri. And these were primarily, almost overwhelmingly unvaccinated people or undervaccinated, and that caused the uptrend. And uptrend is happening not only in Missouri, but this is a national trend. And finally, hepatitis B cases. This graph shows trend a little bit up, but this graph includes all cases, acute as well as new chronic hepatitis B cases. Nationally, they tend to be more like a flat, but here we have slight uptrend, which it's hard to say because, as I said, there's a mix of acute and new chronic hepatitis B cases. But at best, we should be flat here. So there is more work to do regarding Hep B vaccinations in the state. Now, a national strategic plan. You are all aware that we have national strategic plan for vaccinations going through year 25. And the vision is that we should have, through vaccinations, we should accomplish elimination of vaccine-preventable diseases in this country. And there are some goals, such as fostering innovation in vaccine development that I talked about, maintaining high level of vaccine safety, which is extremely important, increase knowledge and confidence in recommended vaccines, increase access and to all routinely recommended vaccinations, as well as protect the health of the nation by supporting global immunization efforts. We cannot be safe in this country when somebody is just one flight away from bringing the most dangerous infection to this country if we do not address this globally as well. That strategic plan has a very specific goals for some infections. For pediatric vaccinations, for adult vaccinations, there are very specific goals, what to happen, what needs to happen, what kind of vaccine coverage we need by year 25 and then by year 2030. Now let's look how close we are to those goals in Missouri. This is vaccination coverage for MMR for little kids in Missouri, and the most recent number is 92.6. The goal for 2025 is about 95% at least. So we are pretty close, so we can smile here, right? Yeah, don't get too excited. It's going to go downward from here. Then there is a national goal for non-medical exemptions. The goal is to have no more than 2% of medical exemptions by year 2025. We are at 2.4% right now. So we could be concerned here because this is not easy to close this gap. Now, for those DTaP vaccinations, the most recent number was about 75.5% for Missouri. The goal is 85%. So again, there is another reason for concern because we have to close this gap just in 2 years. 7 serious vaccine coverage. This is not specific goal in the strategic plan, but I just want to show you that when it comes to 3-year-olds, we are doing better. That tells me, gives me a little bit optimism that we will get to that goal of vaccinating small children. This is polio. Polio is not in a strategic plan as a specific goal, but I want to show you because of what is happening with polio. As you know, the polio case happened in New York State in an unvaccinated person, so maintaining vaccine coverage is important. And we about 93%, that sounds good, but if we look back 10 years ago, it was more than 97%. And look at trend is kind of going down, and we cannot accept that. We need to go back to old numbers. Now, HPV vaccination coverage among adolescents, we are at 59.3% as of last 2 years ago, which is very close to national average. Goal is 80%, and that seems like a big concern if we can close this gap. Regarding flu vaccinations on those aged 6 months and older in Missouri, we are at 49.9%, most recent estimate, which is just 1 percentage point below national. The goal is 60% by 2025, so that's another cause of concern. If we look a little bit more closely, we see that for flu vaccination coverage, the trouble is mostly the 18 to 49 age group, where we have the lowest vaccination coverage in like only 30% range. And if we look by racial composition, black non-Hispanic population is lagging behind whites in flu vaccinations. Influenza coverage among pregnant, Missouri is at 64.8%, which is close to national estimate. but the goal is 80% by 2025, so that's also makes us concerned. Now pneumococcal coverage. Pneumococcal coverage among adults at 72.9% in Missouri. Goal is 90%. So that's a big concern because that's a big gap to close just in 2-3 years. And finally, vaccination coverage with pneumococcal vaccine in high-risk group people, which is the most important, to vaccinate those people who may die from pneumococcal infection. And that rate is 32.2% in Missouri. And the goal is like 60 just in a couple of years. So that kind of makes us desperate, right? So that's what's going on. And why I'm saying this, I am not saying this just for presentation. There is a reasoning behind it. We need to maintain our herd immunity thresholds. We need 92% at least for measles. We need 94% for pertussis. And that doesn't mean that if Missouri has a 94% coverage for measles, it doesn't matter if your community has 60% coverage for measles. Those outbreaks do not happen statewide, they happen locally. So you cannot say, oh, my district has 60%, but Missouri is 94%, so I'm not gonna sit around. No, outbreaks happen locally, and you can have a huge outbreak on your hands, even though the state looks good on the paper. If somebody thinks like this is a speculation and it's not going to happen, I have one word for everyone: Russia. Russia was a highly vaccinated country, but when Soviet Union disintegrated and the vaccine manufacturing was not happening and people, there was economic collapse, people didn't care about vaccinations, just in a few years, diphtheria cases went from almost none to hundreds and thousands. That's how quickly it can happen. So this is a big, most recent, very clear lesson to us that we do need to maintain those herd immunity thresholds. They are there for a reason. And you do need both. You need a good vaccine and you need a good vaccination coverage. Otherwise, you're not reaching herd immunity. If you have a great vaccine but no vaccinations, you're not going to reach it. If you have so-so vaccine and great vaccination rates, still you're not going to. You need a good vaccine and good vaccination rates. Of course, we need to speak about COVID here today and talk about COVID vaccinations in Missouri. Before we jump to vaccinations, a little bit about epidemiology of COVID. This is data through end of March of this year. Overall case rates per 100,000 in Missouri, you see 29,000 per 100,000 population. This is a cumulative from the beginning of pandemic. So you can see if we look at other states, we are somewhere in between, more on the low side of case rates. If you look at death rates, we are kind of in the middle of the states, more on the higher side. So why is the cases we have on the low side, but the death is in the high side? The only explanation comes to your mind immediately is that Missouri hospitals, Missouri doctors, Missouri State Health Department, they are not doing a good job. And that's why we have more mortality than other states. But if you do statistics correctly, which is instead of looking at crude rates, you look at adjusted rates where you adjust for age. It's not fair to compare Arizona to Florida, which is a retirement home for the United States. They have a lot more aged people there. How can you compare them with crude rates? And once you do adjustment, look at what happened. Missouri was more on the high side, right? Now you adjust for age, density of population, comorbidity, all of a sudden, we are on the low side of death rates per 100,000 population. Look what happened to the states. The New York state, the Florida state, here they were more on the high death rate kind of states. Once you do adjustments, it's totally different picture. What happened to Colorado? Colorado was like an almost exemplary state in terms of low death rate, but look at them when after adjustments were made. It totally changes. I'm just wanted to bring this example here because it's a slightly different topic, but be skeptical and critical about all these endless rankings you see because they are not done by professional people, and comparing raw numbers is never a good idea. And that's the reason why CDC doesn't do rankings of states, because they know they cannot simply take crude rates and rank something. So this is just my advice in terms of interpreting all different publications and rankings, often written by people who are not public health experts, and there we have a lot of would-be epidemiologists these days, especially with pandemic, writing and speaking a lot. And now going to vaccinations. In terms of primary series for COVID vaccinations, Missouri has 59% coverage, which is nearly 10% below national average, and that's not what we want. And when we look by county, St. Louis County is the highest, most vaccinated, 69%, which matches the national average. The Boone County is kind of right after St. Louis County, and St. Charles County and Kansas City metro areas. But many parts of the state much lower, down to 25% in one jurisdiction. And now looking at bivalent booster vaccinations, Missouri at 14.5% as end of March. That's low, but the country wasn't much better either, 16.5% for the country. So it's a problem everywhere. And then when we look at the county by county, that is even more striking. St. Louis County, nearly 22%, and the rest of the state, some don't even register, single digit bivalent dose vaccinations. Now regarding equity and the vaccination. This is a map of the United States by county. And if you have a high social vulnerability index and you want to provide the high vaccination coverage in such areas, you will be in this purple box, the top purple box, top right. And if you look at counties in Missouri, we don't have any. We may have a slight purple, but no dark purples. But states surrounding us also don't have that many purple color. There are very few counties in the country that do have this purple color, meaning that they have high social vulnerability areas with good vaccination coverage. So that's another thing where we need to improve our work. Now, regarding immunity, after nearly 3 years of pandemic, we acquired immunity, some from infection, some from vaccination, and this is estimate, seroprevalence study estimate, as of end of September of last year, 94.8% of Missouri residents estimated to have some evidence of immunity. It is important to interpret correctly. Often people understand, oh, 95% in Missouri are already immune. Why do we need this vaccine? Stop calling me. The problem is that doesn't mean that 95% are immune. That tells you that at some point you were either vaccinated or you had infection. Doesn't mean that you are protected. For some people, they will be protected. Some people will be protected from hospitalizations. Some people will be protected from death, but everybody's going to be different. And if we don't continue those booster vaccinations and we don't have more reinfections, this number will go down. And as a community, we all become susceptible to whatever next variant comes around. And to close the COVID topic, this is my favorite topic slide every time I talk about COVID, because it shows power of immunity and power of vaccinations. Look at the beginning, the very beginning on your left. Very little cases compared to what happened later. The cases were very low, but look at the death rate. This is disproportionately high. But when over time, within every next wave, that discrepancy between cases and death rates is getting smaller and smaller. And here we are today at the end of the curve, where today we have a lot more cases than we were having in the beginning of pandemic still. But the death rates are much, much less. That's the power of immunity. And that's how vaccinations work, as well as natural immunity, of course. So what is a future COVID vaccination policy? When I was preparing this presentation, I put this on the slide, and then this actually happened already just a week ago when FDA dropped the authorization for monovalent vaccine, and it's only bivalent vaccine now. And what I was saying here is that we need to harmonize primary and booster vaccines, so we have one vaccine, not the different vaccines. So that's already happened. Now we have bivalent vaccine for primary and booster vaccinations. There are plans to have a yearly shot for COVID, just like a flu shot. But the problem is that flu is the seasonal virus. So you give one shot, and it mostly helps throughout the flu season, but the COVID is happening throughout the year. So it's not clear if one shot is good enough for some people to last the entire year. And still today, we do not know what exactly is the level of antibodies that will protect you from infection. And so-called correlate of vaccinations, correlates of immunity are not well established yet. So if we do have one shot per year, this is going to be probably mostly for general population, just the one shot. And for those who never been vaccinated, like young children or older individuals or immunocompromised people, that likely will be two-dose vaccination. We also need alternatives to mRNA vaccines because people have fear. They've been scared on purpose to death. And there are some side effects of vaccine, we know. And alternative could be helpful for some people. For those people that Dr. Miller was talking to us, the ones who like bargaining, said, here is your bargaining chip. You say, oh, you don't want mRNA. I have plenty of Novavax right here. It's not an mRNA vaccine. So we need those alternatives. And nasal vaccines. Nasal vaccines is going to be a big deal if it works out. But as simple as it sounds, actually technologically they are more challenging to make than injectable vaccines. But they make a lot of sense. There was a study out of Sweden a couple of years ago. They looked at healthcare workers who were infected before they got vaccinated, and then they compared those to healthcare workers who only got the vaccine. And those who were infected actually had the IgA antibodies in the nose specific to SARS-CoV-2, but those who were vaccinated, they did not. And what that means is that if we can develop vaccine to produce enough IgA antibodies right there in your nose or in your upper airways, we can stop virus right there, basically achieving sterilizing immunity. Because with current vaccines, we let virus to come in, and then we're trying to grab it. Here, you are trying to stop it right at the door. It's like having bouncers at the door in a bar. You're not going to let them through. And IgA antibodies can do that because they have 4 arms. They can grab you with 4 arms, unlike IgG antibodies that have only 2 arms. So that's why theoretically they are more effective. But as I said, it's technologically challenging, and also safety issues, because some of them will be live vaccines, some of them will be mRNAs. There is at least 4 nasal vaccines in clinical trials right now. Hopefully it works out. And then while I prepared this presentation, Project Next Gen was announced just a week ago, as you know. This is a new $5 billion initiative to create better vaccines for the reasons I told you for COVID and monoclonal antibody treatments, because with those new variants, we basically ran out of monoclonal antibody treatments because they are not effective anymore with new variants, so we need new treatment. And we need vaccines, as I said, for work across different range of different variants of SARS-CoV-2. And we need a nasal vaccine, which is also included in Project Next Gen. But this is going to be all not easy to do because vaccine translation going forward is not going to be as easy. Taking those projects, the science ideas that I just told you, and transferring them into human clinical trials, that's a complicated step to make. And we need to conduct now clinical trials when we don't have people who are immunologically naive to SARS-CoV-2 anymore. Everybody was either vaccinated or infected. Where do you find the person who never been infected or vaccinated? So it's going to be very difficult to conduct those trials. And there is a talk about using immunobridging instead. What is immunobridging? Immunobridging in vaccinology is that instead of conducting full efficacy trial with bringing people into clinical trials and then looking at the infections, you look at the correlates of immunity and compare them to the previous vaccine. And just looking at those numbers, deciding efficacy of the vaccine. And of course, the vaccine needs to be produced under good manufacturing practice required by the FDA, which is costly, and also you have to do meet multiple regulation requirements. So after we did all that, and we have those new great vaccines, vaccines themselves do not save lives, but vaccinations do, and here is your job. So everything is waste if you don't do your job, and that's why you are so important. And our future efforts in vaccination should be on better logistics and also vaccine equity regardless of socioeconomic status. If we do not vaccinate everybody, we cannot control vaccine disease, vaccine-preventable disease, or we cannot eliminate it. Interestingly, there are different innovations. I'm not advocating to do this in Missouri, but just to show you scope of ideas. When there was an Ebola outbreak in Western Africa, those countries don't have digitalized medical records, the Show Me Vax system or anything like that. So you needed to vaccinate person and then make sure they come back in 2 months' time for another dose. And what they did, they developed biometric identification. The person comes for vaccination, they scan your iris, and then you go, you get your vaccine and you go. And then next time you come, they scan your iris, they know you got one vaccine or you got both or you don't need any. So that's the way to identify. And that was especially important in Western Africa because nobody wanted to be associated with Ebola. So getting vaccination in their mind was associated with Ebola, and nobody wanted that. And doing this biometric scanning was more kind of privacy for those people. We need to address hesitancy, and Dr. Miller talked nicely about that, and this is not an easy issue. And we need ongoing campaigns, especially education and engagement in hard-to-reach communities. The obstacle that you know well is the vaccine fatigue. And I just want to bring this one paper, which is very recent paper, this March published. And that was a survey in Austria and Italy when they surveyed thousands of people to see what is the determinants of vaccine fatigue. And what they found, and it was published in Nature, what they found that concluded is that vaccination campaigns should be tailored to subgroups based on vaccination status. Why? Because they all have different needs and fears. Among unvaccinated, messages conveying community spirit had the most positive effect. So telling someone that we are in this all together, if you vaccinate yourself, you are protecting your family, your neighbors, so forth. That worked in unvaccinated. In those who got 1 or 2 shots, positive incentives, cash, vouchers were important. That was kind of surprising for researchers. Why would someone who already vaccinated themselves still interested in this? And then among triple vaccinated, the vaccination readiness was better once the new vaccines were offered. The vaccines adapted to new variants. But what was discouraging to them was the dissensus about should you get the bivalent or you should not. And we have this discussion even today. If you look at the literature and internet, the different opinions by experts, and there are some making very legitimate points. but this census is not good in increasing vaccination rates. So overall, triple vaccinated were more likely to get vaccinated in any scenario. The unvaccinated were least ready to get vaccinated under any scenario, and those with 1 or 2 doses were kind of in between. So they recommend that long-term success is only through improving trust with public. And here I wanted to bring you a study that is not published yet, but it was accepted for publication in February. This is a study done by Missouri State Health Department and our partners at Deloitte, which we worked with them throughout the pandemic. And here we looked at how to design the best messages to encourage vaccinations. The study is title is Population Segmentation for COVID-19 Vaccine Outreach. And this is a clustering analysis. So we used machine learning and behavioral science to identify different segments of population, what is most important to them. And we identified 10 clusters using k-means clustering analysis. This is the machine learning thing, using 18 different variables. And each the segment had its unique geographic, demographic, socioeconomic, and behavioral patterns. And outreach strategies were developed based on that segment. For example, you see most of Missouri is in purple. And this is what? You know well Missouri's map. This is mostly what? Small town, rural Missouri. And what was the most important to them? Discretion, privacy. Because of the social backlash, they're most worried getting vaccinated so that it's private information. Not every neighbor knows about that. That was the most important. Now look at green. What was most important for them? This is population in the 64-40 corridor. There's a lot of suburban and urban population here that to be in control. They didn't want to be people who were told that you need to get vaccine. They wanted to feel that I'm choosing the vaccine, I'm choosing the time when I want to be vaccinated, and I'm choosing what type of vaccine I want. That was important for them. And there is little one in blue, you cannot see well on the map, but if you blow up St. Louis map or Kansas City map, that you see this blue color. This was actually a big chunk of Missouri population, but it's all urban, and you don't see it well on the map, but it was a big size of Missouri population where you didn't really need more convincing to get vaccinated. What you needed is to make it as easy as possible, anywhere, anytime, on demand. That's all they cared about. So you see how different, within one state, how different people are, what their fears are, what their needs are, what their feelings are about this. So hopefully this is innovative kind of approach, and hopefully will become more kind of routine. And speaking of vaccination policy, of course, there is an elephant in the room. It's a vaccination mandates. As you know, Missouri State Health Department, we did not endorse any widespread mandates. We did not enforce or encourage it. But that happened in many states, happened in Missouri with different employers. Just want to give you overview of what's happening across the world. You see that there are different types of vaccination mandates. The most popular, the one you heard the most probably, is no jab, no job. And that was mostly applied to government employees and so-called the critical workforce. And in private sector, of course. That was used actually not only in the United States, but in many countries across the world. Healthcare worker mandates were also popular in many countries in the world, and states, in some states in this country. And then there were also internal vaccine passports, so that you could go to restaurant, you could go to fitness club, you can travel. Those were popular in Europe and some other countries, as well as some states in this country. School-based mandates actually were not that popular. Only several provinces in Canada used it, several states in this country used it, and a couple of other countries. and then full county mandatory vaccination or full population mandate for the elderly. That was used also in a handful of countries. So after seeing this experience with mandatory vaccinations and the backlash, of course, honest scientists, the scientists with integrity, they wanted to evaluate that. And I wanted to share with you this great paper published in BMJ Global Health recently, where they looked at all this experience. And their conclusion is that mandatory vaccination policies, science behind is questionable, and they can do more harm than good. Their opinion is that we should revert back to public health trust-based policies rather than coercive vaccination policy. And this is a paper written by researchers from different countries, from different high-profile institutions, by people who are knowledgeable in public health law, people who are knowledgeable in epidemiology and vaccinology. They looked at the issue with the framework of behavioral psychology, political and legal effects, socioeconomics, and integrity of science and public health. Through this kind of wide framework, even if you look at, for example, I don't have time to go through all this, I don't want to bore you with all that. Just most impressive is the behavioral psychology, the reactance. Reactance is a known behavioral phenomena when you are forcing something on somebody and they feel that their freedom and their freedom of choice is threatened. And naturally, as a human beings, they revert to opposite behavior. They become non-compliant, they are hard to persuade, and what we saw very well, and we're seeing until today, some people use a reverse psychology because they use somebody's reactance to make them do the opposite thing. That's exactly what anti-vaxxers were doing, using those fears of people in order to make them not to vaccinate. Anyway, this is just one paper, but I wanted to bring up here because it's hard to disagree with it. I think there's a lot of truth here. Overall, vaccine mandates been used for many years. The first precedent for vaccine mandate by the government goes back more than 100 years ago in a case of Robertson versus Massachusetts, when they said that vaccine can be mandatory if government wants to prevent a lot of death and disability. They have that power, even if your liberties are jeopardized. And for 100 years, with many challenges to that, courts always stuck with it. Why? Because the principle used in those policies was principle of proportionality. In public health ethics, principle of proportionality requires that benefits of public health intervention must outweigh liberty restrictions and associated burdens. And until very recently, that was the case. But unfortunately, some people got carried away, and we saw extremes. I remember opinions of people who were saying we have to be masking until the last person has COVID. Imagine that. We listened to these crazy ideas. Or the other side said, we can't take vaccine because it's going to magnetize you and then government will be tracking you. Do you think these people care about the principle of proportionality? Or are they even aware of it? No. So that's why we need to take a deep breath and evaluate all the experience from the pandemic and go back to common public health practice, common public health sense, and give public health the driver's seat, finally. In conclusion, what we can say that vaccines are most effective and cost-effective disease prevention tools, and it is our duty to stress the importance of vaccination for individuals as well as the communities. Vaccine in the vial is 0% effective, even if it's the best vaccine in the world. Further, the more VPD, vaccine-preventable disease elimination in Missouri is feasible with new technologies, novel vaccination strategies, robust immunization information systems, rigorous communication strategy, and of course mitigating inequities in vaccine coverage. We need improved surveillance and outbreak investigations, consistent funding, which is very important, and political will, of course, so that we can provide additional support to the goal of vaccine-preventable disease elimination in Missouri. And I will stop here. Thank you.